Good afternoon, everyone. Welcome. And we are thrilled today to welcome Marie Ba. Marie is the director of the Ouagadougou Partnership Coordination Unit. She's a leading advocate and actor for women and girls in the region of West Africa. So as the director, Marie leads collaboration, coordination among the OP stakeholders, and those include ministries of health of 9 country partners, the civil society organizations, implementing partners, as well as international and donor organizations. Marie has worked in health and development in West and Central Africa for over 15 years. She's managed programs and projects for leading global philanthropies in international NGOs. She is based both in Washington, D.C., but today in Senegal. And her attention firstly focused on technical assistance to projects in Burundi, the DRC, Mali, Rwanda, Sierra Leone, and more recently efforts to improve lives of women and girls in the 9 OP West African regions, which she is going to talk about. And this links very much to many of our work here in the department around family planning issues in the region. Marie holds a bachelor's degree in social and behavioral science from University of Maryland College Park, right next door. And a master's degree in international development and peace conflict resolution from American University in Washington. Marie, we are absolutely thrilled to welcome you, and you have the mic.
Thank you so much, Carolyn, and it's a pleasure for me to be with you and be able to talk about this partnership that I have very much deep in my heart. And I've studied, as Caroline has mentioned, economics and international development, as well as government politics in the US. And I always had a little inkling because there wasn't much conversation at the time, and it's probably still the case, around Francophone West Africa in particular. And I assume because of the language barrier, because it's very far, because it's always the same issues. So I'm very excited to be able to present on this partnership that we created back in 2011, and that is still successful. And for us is a success story in the region, and be able to provide a little more context to you all about Francophone West Africa. So thank you so much for having me. I'm going to be talking today about the Ouagadougou Partnership, where we started when back in 2011, then how we decided on the different phases that we had and that we shared, that each were about 5 years, where we are now and what we're aiming to achieve by 2030, which is our next goal, which we've aligned with the development goals of the UN development goals, the SDGs. So as you will see, I'll start first just introducing what the Ouagadougou Partnership is about, what our goal is, what our objectives are, and who are the different partners. So you have on one side, it's an equal partnership between donor countries, but also Francophone West African countries, where usually we've seen not only the lowest in terms of contraceptive prevalence rates, but also incidentally the highest mortality rates also. And so you have countries which geographically are of relatively small size, and they're comprised of Benin, Senegal, Burkina Faso, Côte d'Ivoire, Guinea, Mauritania, Mali, Niger, Senegal, and Togo. So those 9 countries taken individually are of relatively small size, especially compared to the Nigerias of the world or the DRC. And so they usually garner less attention. The fact also that we are French-speaking countries add another layer and another barrier with the donor community. And so on the other side of the partnership, you have these donors and partners who traditionally have funded family planning across the globe. In particular, we started with the Bill and Melinda Gates Foundation, the Hewlett Foundation, USAID, UNFPA, France. But in recent years, with the added interest that there was around the Ouagadougou Partnership, we were able to add in donor countries and donor institutions like the Kingdom of Netherlands, but also FCDO, the Children Investment Fund, as well as Canada as a group of donors. And needless to say that these are not the only donors that are funding family planning, but these are members, donor members of the Ouagadougou Partnership. And they share a set of data, of funding data as well, and what their investments are. And so our role as the coordination unit that you see in the middle is to, as much as possible, have those donors be able to align their investment cases to the priorities that the countries have set up. Now, it's easier said than done because every donor organization obviously has its own areas of interest, the impact that they want to have across the globe, but also in this region. And then you also have the set of commitments and priorities that are set out by countries. And so what we try to do within the coordination unit is to make sure that there's one, alignment, two, that we're sharing best practices, and three, that there's scale up of some of the pilot projects that are taking place in the region. And so this coordination unit is based in Dakar, the reason why I'm in Senegal. Now, if I touch on, you'll see two phases here. One that went from February 2011 to December 15th and 2015, sorry. And then the second phase started in January 2016 and went all the way to December 2020. And so what we did, we needed a common indicator that everyone could gather around that would be quantitative and numerical, and that would be easy to track. And so we decided, instead of having a plethora of indicators that would be hard to track, we would go with the number of additional users of modern methods of contraception. And so we set out this goal. There's a whole calculation that goes into this with Track 20, one of our partners who's funded by the Gates Foundation, to decide how many additional users were ambitious enough for us to be able to reach, but weren't too low that it was just way too easy. And so we set out in February 2011 this goal of 1 million additional users. And these are, again, modern methods of contraceptions, not the traditional ones. We ended up at the end of that emergency phase, is what we called it, reaching 1.3 million additional users. And then the second phase, we decided to double that goal and went with 2.2 million additional users. And by the end of 2020, we had reached about 2.5 million users. And so that's the reason why we celebrated what we think those two phases are successes. And those two numbers might seem very low, especially, like I said, when you compare it to countries like Nigeria or DRC that have much more dense population. And so you would be able to reach those impact and objectives maybe with just one province or just one country. But to reach those objectives, what you also have to know is almost all of the 9 countries, I think about 6 out of the 9 countries, had to double their contraceptive prevalence rate to get to these 1.3 million additional users, and then the 2.5 million additional users. So there was a lot of emphasis on the contraceptive prevalence rates, trying to prevent discontinuity of services when women went to health centers. So it's no small feat for us, even though the numbers might seem small when you compare to a larger country. So where we started in 2011, it was this conference that took place in Burkina Faso. And if some of you are familiar with some of our 9 countries, out of the 9 countries, Burkina Faso is really one that has the most progressive laws and views when it comes to women's rights, when it comes to family planning. I always get asked the question where that is coming from. I think it's a culture that Thomas Sankara at the time had instilled in the country, and they have this very progressive vision. So the president at the time, Blaise Compaoré, decided to organize this conference on population because they were seeing how the demographic indicators were just getting out of control, especially compared to the economic indicators. And so he called in partners and stakeholders from Burkina Faso, but also from neighboring countries. And that's where these 9 countries formed, including Burkina Faso, and decided to have that conference. And the donors who funded that conference and took stock of the major issues that were taking place in the region, the fact that it wasn't talked about as much as other regions, the fact also that in terms of funding, compared to Anglophone countries, the Francophone countries were funding, the donors were funding 75 cents to every dollar in an Anglophone country. And so there was a need to reposition family planning as a priority, but also being able to decrease the maternal mortality rates in the region. So in 2011, progress was pretty slow in terms of the users of modern methods of contraceptions. And if you see here on this chart, from 1990 to 2011, there were only about 2.7 million additional users that were added to the population that was already using contraception. And so there was, out of a population of hundreds of millions. And so there was this emergency need to increase the size of the population that was using contraceptives, for one, to increase the contraceptive prevalence rates, because there was demand, there was an interest from women to be able to use contraception and family planning. But for some reason, the countries were not able to not only respond to that demand, but also even create that demand and having the right information for women to make informed decisions. So at the time, the objectives were pretty simple. There was a momentum because of that conference that took place, because it took place and was organized, again, at the highest level, the presidential level. And so the idea for this partnership and its coordination unit was to maintain the momentum and the acceleration, being able to link family planning with women empowerment and autonomy, being able to scale up the high impact practices. There were already some practices that were working, evidence was being built against those practices. And so the need to scale them up, a lot of projects were being implemented in one region of a certain country, but even if we saw sometimes the results, the countries were not able then to scale them up at the national level. So that was an objective of the OP. Another one was to be able to follow the progress against the commitments that the countries had made at the International Conference for Family Planning in London, the International Summit, on Family Planning in London in 2012 and in 2017. All of the countries, and including the 9 OP countries, made commitments. Some were financial, others were political, and they also had I think the third one were operational commitments that they were making, that they were going to reach a certain goal, or they were going to fund up to a certain level by either 2017 or 2020, and now the new deadline is by 2026. And so another objective as well was for the OPCU and the OP, again, a large agenda of ours, is to examine how to better align the activities, the funding, and the objectives. And that's the work, the coordination work that we're trying to do with the donors and the countries. And when we speak of countries, I should note this, we're speaking of not only government representatives, and it's mostly the Ministry of Health, but not just the Ministry of Health. In the beginning, we were very focused on the health aspects and the Ministry of Health. But then when that second objective came into play of linking family planning to women empowerment, we started working a bit more with the Ministry of Youth, the Ministry of Women's Affairs, so that we wouldn't just be exclusively talking about health when it comes to family planning, because of all of the advantages that it provides. So those were the 5 main objectives that the OP had set out. And so in terms of an acceleration, again, I mentioned that 2.2 million additional users where that we track. We do track every year and see every country has a goal that they're supposed to reach, to be able to reach that regional objective, and it's divided by year. And it's all weighted with the demographic weight of the country. So obviously we're not expecting the same number of additional users from a country like Benin with a relatively small population size and density than a country like Senegal or like Burkina Faso or like Cote d'Ivoire. The second step toward acceleration was those commitments that were made during the Family Planning London Summit that I just mentioned, which gave new energy in 2017 and in 2012 to the community on family planning issues and challenges. We brought in new donors. As I mentioned, we had a set of donors that started the Ouagadougou Partnership, but then we brought in the Children Investment Fund, Netherlands, Canada, FCDO into the group of donors. And then the motion tracker is this tool that we use in country to track the accountability, but also track the commitments that were made by the country. And it's really a tool that's used by civil society to uphold some of the commitments that the countries have made. And so, for example, Cote d'Ivoire had made the commitment that they would go from 400 million CFA domestic funding per year for family planning to 2.5 billion, which is a huge increase. And they actually upheld that commitment at the last OP annual meeting that we had in December in Abidjan. And so the motion tracker is this tool that we use with civil society to be able to track accountability and track respecting those commitments. In terms of replicating best practices, one way we ensured within the Ouagadougou Partnership that we were able to influence policies and have policy change at a certain level, especially the ministries of health, were in the OPCU, so the coordination unit, organizing study trips. And so I'll give an example a little later in the slides of some of the study trips that we organized within the 9 countries. This coordination between the 9 countries, between the donors, and also between the 9 countries and the donors. The donors caravan is also one way that we were able to influence policies. And if I take the example of Niger, I remember we had a donors caravan, which is basically taking all of the OP donors and even some non-members who wanted to join this caravan. We would choose 3 countries and we would go and look into some of the challenges that civil society were dealing with, some of the challenges that youth organizations and leaders were faced with, government representatives, and also then try to bring in perspectives from other countries. And I remember we had one in Niger in 2017, and then we went back in 2019, and there was a world of difference because we had had study trips in the meantime. There were lessons learned from the Ministry of Health. And so one thing we were able to do, for example, is for the longest time within the Ministry of Health, the family planning was a division, so not even a directorate. And so their mandate obviously was different, their level of funding was different, and their prerogatives were different. And so we shared with a meeting with the Prime Minister that all of the 7 other OP countries had family planning directions within the Ministry of Health and not divisions. And he decided right then and there that Niger would make it into a direction and not a division. And so that was one way that we were able to influence having Niger restructure their ministries of health and give a more prominent role and space for family planning within the ministry itself. So that's an example from Niger. I have a donors caravan, and so we also organize regional meetings, like the OP annual meeting, where we have all of the stakeholders talk about a certain theme for the year, look into the future, and have donors be able to network with civil society or with government representatives. The major challenges back then, again, they go back to some of the priorities that were set, were to be able to keep up with the commitments. It's very easy to have the international community gather and ministries make commitments, but then it's actually keeping up with them. That's been a challenge, and it still is to this day for certain countries, depending on the commitments. Being able to intensify demand creation. For the longest time, the focus was on service delivery. We focused a lot on supply chain issues, on training of service providers, but there wasn't much effort and funding going to creating the demand. Youth and adolescents at the time, and still to this day, to a certain extent, were not able to be decision makers and agents of change. They were mostly dealt with as beneficiaries of services, but not really being able to influence policies, where we know that most of them were dealing with a region where about 60% of our population is under the age of 24. And so obviously, most of these policies are geared towards them. And so we thought it's very important for them to be able to shape these policies. Task shifting also was one of the solutions that were provided with the lack of service providers. So not only having doctors be able to give out certain methods, but also having nurses being able to do that, especially in very far away communities where you had very scarce geographical disparities in terms of doctors being present in the region or not. Another major challenge is the fact that reproductive health and family planning laws, some of them that we have in the region are still dating back to what we inherited from colonial times. For example, in Côte d'Ivoire still doesn't have a reproductive health law. They've been working on one for the past 10 years. There's a lot of opposition from religious leaders. And so they've still been unable to pass that law. And so they're still functioning with the 1906 law that they inherited from France. Senegal has a law that was passed into law by the National Assembly, but still has not been signed by the president. And so we're still dealing with, sometimes lack of coverage, legal coverage for, let's say, service providers. A lot of them are reluctant to provide services to teenagers or to adolescents because they feel like they're not covered by the law, for example. Sometimes it's just an excuse not to provide services for youth. We're aware of that. And there are so many other, obviously, points within the law that would make reproductive health and family planning much easier for uptake in our countries. We also wanted to focus on the multi-sectorial approach. Like I said, family planning was very much treated in terms of health aspects. It was a health issue. Women were dying while they were giving out children because they weren't able to space as much as possible. So we went from this language. I remember when I joined the OP in 2016, some of our countries were still talking about birth spacing. The idea of reproductive health, of family planning, of contraception, because even the term family planning, right, is sometimes that a lot of the youth tell us, we're not planning families, we just want contraception, exactly because we don't want those families. And so, just the idea of talking about contraception could be pretty controversial and taboo. And one thing I think the OP has been able to do is to have those conversations, the language evolve, and get rid of all these taboos around reproductive health. So very often, for example, when we talk to an audience in Francophone West Africa, we don't talk of sexual reproductive health, because the word sexual in and of itself can sometimes be misconstrued as, encouraging youth to be promiscuous. And so we have a goal we want to reach. And so we talk about reproductive health a lot, which everyone is comfortable with. So having this multi-sectorial approach with the youth, with researchers, with communities, and not just with the health sector, has been very important for us also, but still remains a challenge. Another point are the domestic resources. We're in a region where there's so many competing priorities for state budget and government budget. And so one of the first areas that get cut off in the health budget is family planning, because it is considered preventive and not curative. And so they would much rather, if they have to decide between two burden of diseases, they will go with HIV or malaria much more than family planning or reproductive health. So very often we start with a budget for the year from the Ministry of Health or from the country, and then by the end of the year, that budget gets slashed to half, because it needs to go into security issues, because it needs to go into economic issues or military. And so being able to bring in enough domestic resources for family planning has been a challenge. And then the last point is about funding inequities, and those funding inequities are coming from donors. Again, and I think I was mentioning that in the first slide, donors have their own areas of interest, regions of interest, certain countries they're more interested in than others, either because you're either going to collect more impact, or because that's a country that's garnering a lot of interest. Burkina Faso, for example, is one of them. And so there's been funding inequities from countries like Benin and Togo, for example, who don't receive as much attention as the other countries like Burkina or Senegal or Cote d'Ivoire are receiving. So those were some of the challenges. And despite those challenges, we were able, in the first 10 years of the partnership, between 2011 and 2021, to have 19,700,000 undesired pregnancies avoided, 7 million at-risk abortions that were avoided, and 66,000 maternal death avoided. And again, these numbers are coming from efforts from all partners with their funding and their strategies, and the aligning behind the Ministry of Health as strategies and priorities. So that's 2011 to 2020. Then we hit this milestone. And again, when you have partnerships like that and it's successful and everyone is asking you, well, why don't you go into education? Why don't you go into nutrition, for example? So we were being pulled in 20 different directions because we were successful in having those results for family planning in the region. And so we set out to do a stakeholders review of the partnership. Where are we trying to go, and how do we adapt to a changing world? And so we did this massive stakeholders review, and had lots of interviews with donors, with government representatives, with civil society, with youth, with journalists and researchers. And we came up with what we call the OP Beyond 2020 strategy. And it's basically our strategy going from 2021 to 2030, with setting out quantitative objectives as well. And we've tried also to bring in another set of indicators that we thought were important to track. And so the OP has always been built on a very solid base of collaboration. And so we wanted to continue that. Those were the things that we absolutely did not want to compromise. So having that increased coordination between donors so that they could better support countries. A lot of the criticism that was received at the time was that donors were going just very different depending on their interest and not so much on what the countries needed. But for that, the donors also needed the countries to better figure out what exactly their needs were and to be able to budget them. And so that's how we came up with this tool called the Costed Implementation Plan, which started within the OP countries and then were exported to FP 2030, which is our sister initiatives, which is a global one. And so the idea was for country stakeholders within the same country to look at what were the needs, what were their objectives, how were they going to achieve them? So what specific activities needed to take place at the national level so that they could increase their contraceptive prevalence rates, decrease the maternal mortality rate, and other indicators. And so then they started budgeting those because it was very hard when the OP started. Countries were asking for cars, they were asking for health centers, and donors just wanted this much more coordinated, aligned, and based on evidence as well. So based on data, that they be able to set out those objectives and to budget the activities to reach those objectives. The second point that we wanted to maintain that we had been successful in was to be able to improve the exchanges between and within the member countries. At the time, and you would think with the same language, there wasn't any barriers, but there just they weren't talking to each other. There wasn't this regional body that would bring them together either through workshops or through meetings, and sometimes after COVID happened, a lot of it was happening online as well. So being able to improve those exchanges. So very often you have conversations between 2, 3, or 4 countries together on a particular topic and learning how, for example, Guinea was able to strengthen their health systems after they were hit with Ebola and these pandemics. The third one was being able to better organize partners and civil society. There were a lot of, very different coalitions of civil society that were working within country that weren't working at the regional level. So being able to organize them better as core members of the partnership. And then the last point was being able to establish accountability for results among governments, but also among donors and among the other partners. So that we absolutely wanted to keep. And we worked on a new vision, which is very similar than the one we had in the previous 10 years. But the letters you see in bold here, we really wanted to add those aspects of not only quality in terms of family planning services, because at the time we were just focusing on, services, delivery, and it's not that the quality didn't matter, but we weren't tracking qualitative indicators as much. So that was one of the first major additions that we had in our vision. And the second one was to link it better to women as well as young people. We really wanted in our vision to have more room and more space for improving women's lives. At the end of the day, that's what we want family planning to be a tool for. And so being able to serve as a catalyst for sustainable development for all. So it wasn't just family planning for health and women's health, but it was more so for development, countries' development, and communities' development as well. So we have core principles, and maybe I won't go too far into those. I need to look at the time. Go too far into some of these, but we thought, we're going to track ambitious goals, that we use data, we use evidence, we give youth a powerful voice. We believe that we're strongest as a region, but we also recognize that even though we're a region of very similar countries that share the same languages at times, there's a lot of permeability at the border between different populations. But they also have very unique circumstances and unique sets of social norms. For example, you take Niger, which is extremely different from a Côte d'Ivoire in terms of social norms. So we're able sometimes to group them in terms of those, and we'll have Mali, and you see it in the exchange programs that we have very often. Niger, instead of going to Côte d'Ivoire, is maybe going to start to learn also first from Mali, because they do share that set of social norms more than they do with Côte d'Ivoire. So we do recognize those specificities as well. And so our goal for 2030 is to, we did add 3.8 million between the first phase and the second phase. And so we thought we're going to be ambitious again and double that number. And so the idea by 2030 is to add in an additional 6.5 million users and take us to the last bullet that you see, 13 million users of modern contraception by 2030. And so for that, we do recognize that we can't do business as usual. We really need to focus on demand creation. So you'll see the priorities that we set out, that we needed to increase the rate of progress that we had in the region. And so we have a certain number of metrics in terms of youth MCPR. You have to know that the contraceptive prevalence rate is usually this big number, but we had a hard time figuring out what's the contribution that's coming from youth. And so being able to disaggregate that data, being able to provide other youth metrics, maternal and infant health metrics, and quality measures for SBC interventions. Like I said, we used to focus a lot on quantity and not as much on quality. And so that metrics is to help us look into quality of services. And then also being able to look at country investments in family planning. One big shift that we made from the beginning of the partnership until now, in the beginning, most of the focus was on donor funding. And so with the years, we've shifted more and more on putting pressure and focus on domestic funding rather. So we have a youth strategy in place, and we have certain partners like Yield, like Oasis, that we do work with to make sure that they do find a voice within the partnership, that they're able to provide and be part of some of the research and resources that are useful for OP stakeholders, and also being able to support the Francophone West Africa research agenda, which I'll talk about in a minute. And so being able to mainstream youth, establish a vision and a team for them, which we have. So we have youth leads within the region, we have youth focal points, and we also have a group of mentor organizations for those youth, whether it's in research, whether it's in SBC or other priorities for the Ouagadougou Partnership. We do also keep supporting countries' efforts to change social norms, and that's where, for us, demand creation is extremely important, because we see that it's underfunded and it's not talked about as much as it should be. And so being able to support the ministers in terms of their knowledge and understanding, and being able to challenge social norms, to be able to use them as an accelerator for social behavior change, but also the uptake of family planning, and be able to assist the other in-country advocates, because we see that, especially feminist movements, for example, there's a lot of backlash against them. So being able to assist them, because they're one of the most prominent actors in terms of promoting family planning and reproductive health and rights. We also focus on the priorities that are shared across the region, and those are on research, on private sector engagement, which we don't do a good enough job yet. And I do agree that there's a lot more we can do with encouraging private sector to fund, but also add visibility in terms of family planning. A lot of times when we have conversations with them, they would much rather, or are more comfortable because they know more about malaria or HIV than family planning, which can be deemed as sometimes controversial, but that's just because they don't have enough information. So it's our role to educate them so that they can contribute a little better, and helping those companies invest in family planning and investing in the Ouagadougou Partnership. I'm going to skip because I really want to talk about the research agenda. This is I was talking earlier of research and exchange programs that we had. For example, we now have a coordination platform for the 9 maternal and child health directors who didn't used to know each other. They didn't used to work together. So that also helps with documenting the exchanges that are happening. We sent a team from Niger and from Mali to Burkina Faso to investigate the setup that was done in the Ministry of Health, who decided to have a demographic dividend transition specialist. And then Côte d'Ivoire, we planned a trip and funded a trip from Côte d'Ivoire to research gratuité, so free services in Burkina Faso. We're trying to promote free services as much as possible, especially for children under 5 and new mothers and family planning. So finding ways for these countries to replicate and scale up that gratuité. And Senegal, for example, we're funding to work with Mali to model their own national family campaign and being able to integrate uterine cancer screenings within those family planning campaigns that are taking place. So our objective for 2030, again, is to double the number of additional users and reach 13 million by 2030, which is very, very ambitious. But for that, we have to look into supporting youth, supporting countries' efforts, the fact that all of the countries are not at the same level in terms of results. We have Benin, Guinea, and Togo, who are lagging behind for very different reasons. Like I mentioned, Benin and Togo, because of a lack of attention and lack of funding, external funding. Guinea, because they were hit with so many different pandemics, Ebola and others before COVID hit, so very much weakened their health systems. But also the research agenda, which I'll touch on much more right now, which you might be interested in. And then also being able to find solutions for countries in crisis settings. There's the security situations and in the Sahel with Niger, Burkina, Mali, and Guinea that now has a coup as well. But there's also climate change issues in Senegal, for example. Every year during the rainy season, you have a big part of the population in the north that has to be displaced. And so obviously when they're displaced, women no longer have access to quality health services, and that includes family planning and reproductive health. So we've set out our objective, the 6.5 million by 2026. We want to reach at least 4.8 million in the 9 countries. So we've divided up by year. So all of the 9 countries are aware, but we've also divided it up by country. So Benin, for example, for each of the 5 years knows exactly how much we're expecting from them to bring in terms of additional users. And so we have conversations with them throughout the year of how they are able to reach. And one of the best practices in all of the 9 countries that we found are those national FP campaigns, during which time family planning services are free. There are free mass communication campaigns for family planning. And so a lot of the services and products are distributed during those times. So one way Burkina Faso has been able to be ahead of the curve at all times is that they, instead of organizing 1 campaign per year, they've organized 2 or 3 every quarter, for example. But it's getting harder and harder because there's a large number of regions and health centers that they can no longer reach during those campaigns. And sometimes it's a week, sometimes it's 2 weeks. Togo also has those campaigns, but they didn't couple that with communications, which is a big mistake because women then don't know that services are free. They don't know when those services are free. And so we've worked with them in the past to make sure that these campaigns are accompanied and coupled with mass communication campaigns as well. So our priorities are social norms favorable to family planning, research, the same way that we were able to build a community with donors, we have a community with government representatives, another one with civil society and with youth, is to be able to build one with local researchers. Increasing the engagement and leadership of youth organizations, given the large cohort of youth we're dealing with in our countries. A civil society strategy, because we think some of these social norms should be driven, change should be driven by them. The coordination of actions between the different OP actors, being able to tailor the support for countries, and also being able to strengthen the decision-making at the OPCU level. So in the past, a lot of the decisions, even though it's a partnership, were made at the donors level because they had more facility in terms of more ease in terms of being able to meet and make decisions. But we've been able in the past couple of years to find a balance and bring in much more voices from the countries in those decision-making instances. So we have a new set of indicators, like I said. Some of them, the Method Information Index Plus is on around the quality of services, so not just additional users, being able to disaggregate the MCPR and the new users in terms of youth use, being able to also track the demand for modern contraception, there's unmet need, and also the demand satisfied, as well as family planning in humanitarian settings, for which we don't have yet good indicators to track. And so with partners, we're working on what would be good indicators that we're able to track for family planning in humanitarian settings. So where we are in 2023, we've increased the size of the coordination unit. It used to be 3 people back in 2016. Now we're at around 15 of us based in Dakar and based in countries. And you'll see from the titles and the different roles, we have a big focus on civil society, on advocacy, and then also took on FP in context in crisis settings, data and monitoring and evaluation, but also youth and adolescents, sexual reproductive health, as well as communications and research. And so in terms of results, in 2023, we were able to add in about 450,000 additional users. That was 7,000 more than the objective. And we used to reach our objective with a much better margin at the time. So our results they're decreasing. We're still able to reach our objectives, but we're seeing a decline in terms of the regional reach that we have. And so you'll see here the countries that are able to reach their objectives and even surpass that, and that's Côte d'Ivoire, Burkina Faso, and Mali and Senegal. Mali has this beautiful story because for the longest time, for about 10 years, they were never able to reach their objectives, but they focused so much on community health workers and their community policy that now, despite the crisis, they're able to reach and even surpass their objectives. And so other countries like Niger have been very interested to learn from their experiences. And then Niger, obviously, between the coup and the different issues that are happening, security issues, were not able to reach their objectives. And then Benin, Guinea, and Togo, which I always mention, of the countries lagging behind. Mauritania is always right on spot with hitting their objectives. So they're at 9,000. That's what was asked of them. Their population density, obviously, like I said, we can't ask the same results from them than we do Côte d'Ivoire, for example. But if we take the cumulative progress, that's what I was mentioning before, we are below our annual cumulative objective. And that's because some of the countries that are lagging behind are really lagging behind. Niger, Guinea, Togo, and Benin again. And so it's not compensating for the results, the excellent results that Burkina, Côte d'Ivoire, Mali, and Senegal are bringing in. And in the case of Burkina, the amount of additional users that they've been bringing has also been on the decline because of the security situations as well. So young users are increasing, but we feel like they're not increasing fast enough. In terms of, if you look at the chart on the left, between 2012 and 2022, it's still about 30% of users who are from youth that are using modern methods of contraception. And so even though the population size has increased in terms of percentage, we're still at around 30%. Whereas we had hoped that we would have much better gains if the population, that the number of users were increasing, that we would also relatively increase the number of youth users. And so the second chart that you see is the number, the portion of total users that are youth. And so in Senegal, for example, that's where we want to put a lot of our focus. Only 14% of the total users are youth, compared to a country like Burkina and Cote d'Ivoire, where about 37% of the users are between the age of 15 and 24. This is the total demand, which is growing. The unmet need is falling, but not fast enough. We would have liked to have much steeper curves, one going up, the other one going down. So we see that there's not been too much evolution in terms of demand created, as well as in terms of unmet need. And those are two focuses that we want to look into. And so the goal is still 6.5 million additional users, and to take us to the 13 million in 2023, we are at 7.5 million. So we need to accelerate. And these are numbers in terms of global impact since we've started. And so you can easily make the difference between the numbers I showed earlier in 2021, where we had about 17 million undesired pregnancies. We're now at 24 million here, 8 million, around 9 million abortion risk avoided, and 68,000 maternal death avoided. In terms of governance, I won't go too much into this, but this was the balance that we were able to find, because it was very much dominated by donor decisions at the beginning. And so we thought we would bring into the advisory council, the OP advisory council, more voices from the countries. And so Mali, Burkina Faso were added, but we also had a civil society organization from Cote d'Ivoire and a youth leader from Togo, and a expert on family planning from Senegal to help guide some of the decisions that we were making around the OP, the priorities and the strategies. So that was to have more representation from these countries into the Ouagadougou Partnership. And so the role of the advisory board is really to advise the director, review the results, maintain the governance, and establish new structures. So having new members, new donor members, for example, and helping establish the ends for the OP goals, and making sure that we upkeep our mission and our vision. So you'll see here, the Gates Foundation and the Hewlett Foundations are funding the OPCU, so they're observers, but they're not part of the OP advisory board. We thought it was best to separate those two. Now, if we go into the research agenda, which I think is the last big topic that I wanted to mention here, we did realize that if there was one stakeholder that we weren't working enough with, it was local researchers. And a lot of research that you see on FP and SRHR in Francophone West Africa is done out of these big organizations in the West. A lot of them written in English. Sometimes that countries have absolutely no idea that research is being done. And so we thought it was important to undertake and publicize important policy relevant family planning research that was done by local research institutions, but also providing opportunities for capacity building for those institutions. And so we planned this 2-year outcome and have this Family Planning Research Advisory Council. We provide funding, the OPCU directly. We have a fund of about $1 million and are inviting donors to join us to have policy relevant research that we would re-grant, and being able to build an infrastructure to implement the agenda. So in the Research Council, we currently have local research institutions, as well as PRB, PMA, UNFPA, but also Track 20 that are part of this. And so what we did is we worked with local decision makers within the ministries of health. Where did they think that certain policies, if they had better evidence, they would be able to influence them? And so once they gave us those priority areas, we put out an RFP for local institutions, local research institutions, to build evidence. And the idea for us is not just to come out with the evidence, is also to be able to influence policies at the end of that process. And so we hired a senior research manager. We started funding in 2023. It was 3 projects, and I'll talk about them in a minute. And then being able at the end to disseminate the findings, but also to advocate for policy change. So this is the timeline that we had in 2022 for the proposals, and having a very inclusive process to be able to document and finalize which themes we wanted to research. And so we have workshops we put together. We have a mapping of those research institutions that is available to all the stakeholders and partners, being able to provide capacity building for institutional capacity building for those 10 research institutions, because what we found is that you have a lot of very competent researchers individually, but that keep hopping from like one institution to another because they don't have enough funding. And that's because the institutions in and of themselves are pretty weak. And so the idea is we provide institutional capacity building for those local research organizations. They're then able to attract funding, whether local or international. And then you won't have as many researchers hopping from one institution to another, which weakens even more the institutions. So we have the first cohort of granting that we started in 2023, and then the skills transfer according to the results that we obtain. And so the 3 research, 2 are out of Burkina Faso, 1 is out of Niger, 1 this competitive process. 1 is the research is on evaluating free services and the impact that it has on adoption or discontinuation of family planning. The second one is on documenting domestic solutions for youth adoption of FP service. So what are the social norms that are hindering youth from adopting family planning services in our region? And then the third one is on analyzing data for discontinuity by population segment. And that's done by IASP, which is operating out of Burkina Faso. There's an institutional capacity building element to this. And we didn't just go with the 3 research institutions. We looked at the 7 who had very good proposals and bids, but just not enough funding for us to fund them, and decided to include them into that capacity building that we were providing. And that is done by Agency for All. They're funded by USAID. So some lessons that we learned, it's very time consuming and just as much harder than we thought to have this inclusive and participatory nature in the grant selection. We had to include youth, civil society, government representatives, Ministry of Health. And so we didn't include donors in there, but just to get consensus on which themes needed to be prioritized and which countries and geographical coverage was a huge undertaking that took much longer than we thought it would. Another lessons learned is to have rigorous and robust research data, but taken into account from the get-go the policy and decision-making that we wanted to influence, so that we could increase our chances to influence that policy at the end of the process. So we didn't just end up with like great research, but absolutely no change in policy. The third one is the advocacy process for the use of that research. And so we want to use the political opportunities from the OPCU. We have a ministerial meeting that we organize every other year. There's the OP annual meeting. FP 2030 is putting together a presidential task force with the presidents of several countries. So being able to advocate at these different levels that we would have identified with the decision makers, which level do we need to advocate to make those changes happen in terms of policies? And then some of the challenges that we also had in the consistency of the involvement from the directors at the Ministry of Health, given they have extremely busy agenda. So we have a youth strategy, we have a civil society strategy, we have the country support, the research agenda, and the communication. These are some of the activities that we prioritize for 2024. But in large, this is what the Ouagadougou Partnership is about. But I also wanted to provide in there ideas and some of the challenges that family planning and reproductive health is facing in Francophone West Africa. These are different, either annual meetings or workshops that we have with youth in the region. And I hope this was useful. Very happy to take questions and comments. I was being mindful of the time. I might have been a bit long on this, but hopefully this gives you a better idea of some of the challenge that we were facing before, that we're now facing. Some we're no longer facing, and that is a great thing. But in terms of scaling up, that is still a challenge to find those funding. The donor funding it's increasing, but it's not going into those scale ups. So it's still a challenge. Being able to include youth, there's resistance at times from countries. And that has been a challenge, but hopefully that gives you a better idea of what's the state of family planning and reproductive health in the 9 Francophone countries. Thank you so much.
Thank you, Maria. Thank you so much for this very comprehensive overview of the OP. And I think we have a few minutes for questions, either from Zoom or online or in the room. And while I'm waiting for a question, you have a comment from, no, I don't. No, I think they're just applauding. You have a comment from Beth Frederick, who acknowledges the great work you have done with advanced family planning. So if I can start off with one question. David, go ahead.
Thank you for an extraordinarily comprehensive presentation. Very interesting. I wanted to ask the decline in unmet need was rather modest, and yet the increase is very robust. The two seem to be asynchronous, and I was just curious as to what was how that is to be interpreted.
Sure. And there's been a lot of talk around whether unmet need is even a good indicator, because and that's one thing I found very curious when I joined this FP community is when they're determining FP unmet need, they're not asking the women whether in the set of questions that are asked to women to determine unmet need, they don't ask her whether she would like to take a method. And so there's been a lot of talk of whether that is even an indicator that is good enough to track of if there's others that we should. And so I think with time, there's been a decline in terms of interest, in terms of tracking unmet need. But in our region specifically for the Ouagadougou Partnership, that's one of the reasons why we do recognize the importance of focusing on demand creation. But again, if we're successful in that, that will probably just increase the indicator for unmet needs. And so we do also want to make sure that in terms of service delivery also, that we keep gaining momentum and making strides, because then we're just gonna, widen the gap between the unmet need. And you were making the comparison with the demand, right?
Mm-hmm.
Yeah,
Thank you.
It's about population growth and then also greater demand for contraception that is not necessarily met by services.
Mm-hmm.
Right.
I have just one question because I think we need to end because we have a class that is going to come in very soon, but just one question, Marie. How do you set your goals? How are the goals for the different countries negotiated on what kind of data? How do you set those goals?
So it's this formula that we work with on with Track 20 that I mentioned earlier. And what they do is they don't collect data. What Track 20 does is they go with some of the DHIS that are available, some of the ODS that are available, the data that's already collected in country, and they're able to analyze that. And from that, they come up with predictions of what type of goals we should have per country. And again, like I said, it also very dependent on demographic weight. So we don't ask the same of two different countries, but we do, those numbers are shared in advance with the country. So for example, in 2020, we set out that we wanted an ambitious goal, but something that could be attained. And we came up with a 6.5, shared it with countries. They agreed with the numbers and thought that was attainable and reachable with the trends that they were on, recognizing that they would have to be even more ambitious. And then every year there's a consensus meeting because there's been issues before with the numbers that would come out and the countries wouldn't agree that those are the official numbers. And that's why we don't go and collect, we just go with what is already collected from official sources. And so there's a consensus meeting in each of the 9 countries. And once they agree with the numbers that we have and that we were able to analyze from the collections of data that were done, then we're able to publish that. But there's a formula that I wouldn't be able to explain. Track 20 is the specialist in there, Avenir Health, to come up with the numbers, but it's really based on trends. From 2011 to 2021, what we thought was reachable and attainable for some of the countries.
Thank you so much. And I'm hearing students that are eager to start their class. So we're going to end it here. But thank you so much, Marie. And we look very much forward to working with the researchers in the region and OCPU in our research partnerships.
Thank you so much. And we're really looking forward. Any support we can get in terms of research would be very much appreciated. They recognize the needs. And so we're very much looking forward to being able to collaborate on that front, especially. Thank you so much, everyone, for your attention.